Hello guys, today we'll be talking about neonatal jaundice. What is jaundice? How common is jaundice? Is jaundice life-threatening? So welcome to your Health Today with Dr. Yide, where I talk about your health and wellness. I am Dr. Olaide Jaundice. If you're not yet subscribed to this channel, I think you're missing out. Why don't you hit that subscription button right now and notification bell so you get notifications every time I post new videos. Now, straight to the chase. Neonatal jaundice. Let's break down these words. The word neonatal comes from neonate, and a neonate is a newborn child, a newborn baby within the first 4 weeks of life. So any child within the first 4 weeks of life, 28 days, is a neonate. Now, what is jaundice? Jaundice is the yellowish discoloration of the skin and the sclera. Now the sclera is the white portion of your eyes. So when you have them yellow, it's jaundice. Now, neonatal jaundice is this jaundice occurring in a neonate. There are two types of neonatal jaundice: the physiological jaundice and the pathological jaundice. The word physiological means normal, not necessarily life-threatening, while the word pathologic means disease-causing or a disease state. So, physiological jaundice is normal jaundice without any grave consequences, while the pathological jaundice is, must be treated aggressively to avoid kernicterus, a complication we will talk about later. What are the causes of both physiological and pathological jaundice? Physiological jaundice, as we said earlier, is normal and doesn't really require so much treatment. It's caused by buildup of bilirubin in the body. How is bilirubin built up? While the baby is still in the womb, the baby is in an oxygen-poor environment, so needs more hemoglobin, more red blood cells to drive oxygen around the baby's body. So while the baby is in the womb, the baby has a lot of red blood cells. The moment the baby is delivered, most of those red blood cells are rapidly destroyed because they are no longer needed. This leads to excessive breakdown on red blood cells. And where red blood cells are broken down, hemoglobin is broken down as well. Now the word Hem is the iron containing group. The breakdown of hemoglobin leads to the production of bilirubin. That's where we are going. An excessive buildup of this bilirubin and the poor or the liver's poor capacity to mop up this excessive bilirubin produces what we have as jaundice. Hyperbilirubinemia, excessive bilirubin in the blood. So there are two components: excessive red blood cell production leading to increased bilirubin production, and a reduction in the capacity of the liver due to its age, very young age, to mop up excessive bilirubin. Usually for physiological jaundice, it is noticed around second, third or fourth day of life and resolves spontaneously usually. Some of them might require treatment, but most resolve spontaneously, as opposed to the pathological jaundice we'll talk about. Now that being said, let's go to the pathological jaundice. The commonest causes are ABO incompatibility. That's from the blood group A, blood group B, blood group O, AB. When there's an incompatibility between the mother's blood and the fetal blood, the baby's blood, you can have jaundice in this child. This jaundice is expected to appear within 24 hours after birth. Another example is resource isoimmunization, when the mother and baby have different resource factors. One is negative, the other is positive, and there are incompatibility issues. Yes, this can spark off excessive breakdown of red blood cells. Other examples are G6PD deficiency, hypertrophic pyloric stenosis, biliary atresia, breastfeeding jaundice, and breast milk jaundice. Now, I'll talk about these two things. Do not confuse these two things. Breastfeeding jaundice, this occurs when the mother is unable to produce enough milk, meaning the baby is not getting enough milk as he or she should get. This baby is regularly dehydrated, and this can also cause jaundice, as opposed to breast milk jaundice. With breast milk jaundice, the breast milk is actually the problem. Some breast milks have this factor that can cause incompatibility issues with the blood, leading to excessive red blood cell breakdown. So don't confuse breastfeeding jaundice with breast milk jaundice. Other causes of pathological jaundice in a baby or in a neonate are neonatal malaria, that's malaria in a neonate, or an infection, sepsis in a neonate. This would invariably cause rapid breakdown of red blood cells. And when we have rapid breakdown of red blood cells, we have rapid production of bilirubin. What factors make one prone or more prone to neonatal jaundice? Number one is race. Neonatal jaundice has been found to be very common among East Asians and American Indians. Very low in Africans and African Americans. Another risk factor is geographic location. It's been stated that people who live in high altitudes are also very prone to this. Why? The higher you go, the lesser the oxygen concentration. So don't forget that these people that live in high altitudes have a lot of hemoglobin. They need a lot of hemoglobin to mop up as much oxygen as possible. So they stand a higher risk of neonatal jaundice. Another risk factor is genetic makeup. If neonatal jaundice runs in the family, there's a very high tendency that this baby coming would have neonatal jaundice. So there's a genetic predisposition. There are maternal factors that would also encourage neonatal jaundice. For example, malaria in pregnancy or sepsis, an infection, wide blood-borne infection while the mother was pregnant. Another risk factor of neonatal jaundice is prematurity. It is expected that children who are born premature have a higher tendency of neonatal jaundice. Now let's talk about the treatment. There are three basic treatment modalities that have been found to be effective against neonatal jaundice. The very first one, phototherapy. Photo, light, therapy, treatment. Phototherapy, which was discovered in 1950 in England, incidentally, serendipity. The next, exchange blood transfusion and intravenous immune globulin. These modalities have been found to be very effective. However, pathological jaundice has been found to have various causes. If you're dealing with sepsis as a cause, as an underlying cause, this baby needs to be placed on antibiotics to ensure that whatever invading bacteria is eradicated to reduce the excessive breakdown of red blood cells. But I must say this, it is not necessary for every jaundiced baby to be given antibiotics. I have seen so many situations where once the child has jaundice, the grandmom grabs the child and gives oral antibiotics. If no infection or sepsis has been established in this child, it is completely unnecessary to place this child on antibiotics. Jaundice is not an infectious disease. Jaundice could be caused by an infection. If that's the case, you could go ahead to use antibiotics. But if that's not the case, don't bother giving antibiotics. Ensure your doctor or your midwife is aware of the jaundice. They'll carry out tests to see the level to classify if it's physiological jaundice or pathological jaundice. Why am I doing this? The essence of this is to avoid a complication, what we're going to be talking about very soon, kernicterus. Kernicterus is the major complication of jaundice. We want to ensure that this jaundice, this excessive bilirubin, hyperbilirubinemia, excessive bilirubin in the blood doesn't get to the brain. There's something known as the blood-brain barrier, which is very underdeveloped in babies. If this bilirubin gets to the brain tissue, it damages the brain tissue, which could cause neurological or brain damage in the baby or death. So kernicterus should be avoided at all costs. How can jaundice be prevented in a neonate? Before I talk about prevention of neonatal jaundice, it should be noted that physiological jaundice can't be prevented. Statistics show that 50 to 60% of 10 babies come down with neonatal jaundice, whether I like it or not. That's physiological jaundice, the kind of jaundice that is not very dangerous, that starts within second or third or fourth day of life, as opposed to the pathological jaundice. It's also known that prematurity predisposes a child to neonatal jaundice. So statistics have shown that 80% of preterm babies will come down with neonatal jaundice. That being said, other causes of jaundice can be prevented, like malaria. That's why women are given at least 2 shots of IPT, prevention measures against malaria in pregnancy when you live in the tropics. We ensure that you're giving anti-malarials to prevent malaria in pregnancy, at least 2 to 3 doses. We also ensure that you prevent every form of infection. That's why the mother must be monitored from the beginning of the pregnancy to the end of the pregnancy, because we know that congenital infection can also lead to jaundice. Another means of prevention is this: we also want mothers to keep organophosphates far from their babies, because you don't know which of your baby has G6PD deficiency. G6PD stands for glucose 6-phosphate dehydrogenase, an enzyme which ensures integrity of the cell membrane of your red blood cell. If this enzyme is lacking, this child's red blood cells are amenable to rupture at any slightest provocation. Organophosphates like camphor, mentholatum can actually encourage the rapid breakdown of these red blood cells. So we encourage mothers to keep their baby belongings far from camphor. Stop putting camphor, that's naphthalene balls, in your baby's bag. If you just love this video, I would have you like, post a comment, share, and subscribe to my YouTube channel. So we'll meet again, same place, same time next week. Don't forget, health is wealth. Bye for now.